Welcome to this explainer. Today, we're diving straight into the nitty-gritty of decoding ICD-10 CM, specifically the coding basics and medical definitions around abortive outcomes. You know as well as I do, if you're in medical coding or clinical documentation, the difference between a perfectly clean record and a frustratingly rejected claim. Yeah, it usually comes down to literally just one word in a patient's chart. So let's strip away all that guesswork and get you a rock-solid understanding of these definitions.
Okay, here's our game plan for this explainer. First up, defining the abortive outcome itself. Then, we'll look at elective versus spontaneous care, map out the primary coding axis, and finally, we'll drill down into complete versus incomplete events. Let's get to it.
Section 1. Defining the abortive outcome and establishing our baseline medical coding rules.
So, in our highly specific world of medical coding, an abortive outcome is defined purely by physical criteria. It's the expulsion or extraction of all or even just a part of the placenta or membrane. Notice how incredibly objective that is, right? We're looking for very specific physiological events explicitly recorded by the physician. But hold on, because there's a second, equally critical criterion that absolutely has to be met here.
And here it is. The gestation must be estimated at less than 20 completed weeks. Guys, this is a hard, non-negotiable boundary line in medical billing. The moment that gestational age hits 20 completed weeks, bam! You are entirely locked out of the abortive outcome classification and shifted over into a totally different set of diagnostic codes. So remember, expulsion or extraction at less than 20 completed weeks is our foundational gateway here. Now, I know you guys have to navigate a really tricky boundary here. On one side, you've got state fetal death reporting requirements, and we all know those vary wildly depending on what state your facility is in. But on the other side, you have the universal ICD-10 CM rules. A state might mandate reporting at a totally different gestational age, sure, but when you are assigning an ICD-10 diagnosis code, that 20-week rule we just talked about is absolute, no exceptions.
Moving right along to Section 2, elective versus spontaneous care. Here's where we navigate intent in medical documentation.
Before we split our path, it is super important to wrap our heads around a specific nuance of the manual's language. When you're looking at the disease classification chapters of ICD-10-CM, the term abortion strictly refers to a fetal death. This specific terminology is deeply, deeply embedded in the logic of the code set, and grasping that is going to help you correctly categorize whatever subsequent events are documented in that chart.
So the crucial point here is distinguishing the encounter's actual purpose. If the medical record shows an encounter specifically for performing an elective termination, boom, that's classified to Z33.2. But if the encounter is for dealing with a spontaneous abortion, or maybe a complication, you are directed to an entirely different neighborhood in the manual. That's going to be categories 000 through 008. Getting this first fork in the road right is absolutely essential for keeping your data clean.
Oh, and keep this extra documentation rule in mind for elective care. If a termination procedure happens in a hospital setting, you, the coder, have to include the specific procedure code right alongside that Z33.2 diagnosis. Think of it like this. The diagnosis explains the why, but the hospital always needs you to explicitly code the what, the actual procedure that was performed.
All right, Section 3, the primary coding axis, where we categorize the specific types of abortive outcomes.
Now that we're inside the O-code block, we've basically got three core categories to look at. First is category 033 for a spontaneous event, meaning it happened without any instrumentation or chemical intervention. Then there's category 04, which handles complications that pop up after an induced termination. And finally, category 07. This one is for a failed attempted termination, meaning an induction failed and the patient is in fact still pregnant. Actually, there's a really important inclusion note for that last category that you do not want to miss. If an elective abortion is incomplete, it is specifically routed right into category 07, right alongside those failed inductions. So 07 isn't just for when the patient remains completely pregnant. It's also the official home for incomplete elective procedures. Make sure you star that one in your notes.
And that brings us to Section 4, complete versus incomplete. This is the final granular puzzle in spontaneous events.
This brings up a really critical puzzle that I know you coders face literally every single day. How exactly are you supposed to determine completion status from a patient's chart? I mean, you can't examine the patient yourself, right? You can only examine the physician's words. So the big question is, what exact words actually dictate the code? Well, the codes split pretty sharply to reflect that status. Subcategories 003.0 through 003.4 definitively dictate an incomplete status. On the flip side, subcategories 003.5 through 003.9 capture events that are either complete or just unspecified. The manual literally dedicates entirely different blocks of numbers depending on this one single clinical factor. It's that important.
So, to apply the correct code, we have to know the manual's exact medical definition. Incomplete medically refers to the presence of retained products of conception. And listen, this holds true whether those retained products are from a spontaneous event or an elective one. If the documentation clearly states there are retained products, you as the coder go straight down that incomplete pathway. Easy enough, right?
But, what happens when the medical record is vague? It happens all the time. If the chart is totally silent on the completion status, meaning the provider didn't explicitly spell out whether it was complete or incomplete, the strict default rule kicks in. You have to classify it to the 03.5 through 03.9 block, complete or unspecified. The golden rule here, you can never ever just assume an abortion is incomplete. It must be explicitly documented.
Which brings us to arguably one of the most vital takeaways of this entire explainer. The guidelines explicitly state the fact that a follow-up dilation and curettage, or D&C, is performed is not evidence in itself that an abortion is incomplete. The physician makes this determination. Guys, this is the absolute cornerstone of medical coding. Procedures do not dictate diagnoses. You might see a D&C in the chart and logically think, oh, it must have been incomplete. But you cannot code based on assumptions. Only the physician's explicit words can determine that diagnosis.
So as we wrap up this explainer, I want to leave you with this thought to chew on. If follow-up procedures don't dictate the code, how can we ensure our clinical documentation is precise enough to actually survive the strict rules of ICD-10 CM? In a system driven entirely by the provider's exact words, are your medical charts telling the precise, objective story that the data requires? The rules are clear, the boundaries are rigid, and at the end of the day, success depends entirely on closing that gap between clinical action and clinical documentation. Thanks so much for joining me to decode these essential guidelines.